Okay, yeah.
Welcome everyone. Uh, okay. Welcome everyone. Welcome to this Morocco AI webinar series. Today, we are very happy and thrilled to have Kenza Bouzid with us to discuss grounded radiology report generation, where she will detail Maria 2, a large multimodal model that combines a radiology-specific image encoder with a large language model. It is trained for the new task of grounded report generation on chest X-rays. She will also introduce RadFact, a novel evaluation framework leveraging the reasoning capabilities of LLMs to assess the factuality of individual generated sentences and the correctness of generated spatial localizations when present. Kenza Bouzid, our guest speaker, is an applied researcher at Microsoft Health Futures in the biomedical imaging team based in Cambridge, UK. She is currently working on the project Myra, Multimodal AI for radiology applications. The goal of this project is to create innovative multimodal AI technology that assists radiologists in providing effective patient care while empowering them in their work. Prior to Project Myra, she worked on esophageal cancer research to enable large-scale screening of Barrett's esophagus using weekly supervised learning in collaboration with Cited AI. Before joining Health Futures, she obtained a Master in Science in Machine Learning from the Royal Institute of Technology in Stockholm. She also holds an engineering degree in computer science from INSA Lyon, and motivated by her passion to address critical issues in healthcare, Kenza decided to pursue a career in AI research for health. The presentation will last for 30 minutes, followed by 10 minutes Q&A. And if you have any questions during the talk, please feel free to ask them in the Zoom chat or YouTube, and we will make sure to bring them at the end of the presentation. And don't forget to stay for the breakout sessions to meet fellow attendees. And without further ado, Kenza, please, the floor is yours.
Thank you so much for the introduction. Let me try to share my screen. Okay, can you see my screen?
Yes, we can see it, Kenza.
Yeah, hello everyone. It is truly a pleasure to be sharing my work with you today and connecting with the Moroccan community in AI. I hope you all had a wonderful Eid, and thanks for joining us today. Allow me to introduce Myra 2, a novel large vision language model for grounded radiology reporting. This work wouldn't have been possible without all the contributions of the wonderful biomedical imaging team at Microsoft Health Futures, but also beyond, with all our extended collaborators. I have the privilege to work with a diverse multidisciplinary team with various backgrounds in machine learning, HCI, medical image processing, and more. We also work closely with the radiologists that help us shape and ground our research. All right, let me first explain the clinical motivations behind this work. Diagnostic imaging studies are growing in a rate that exceeds the radiology workforce, according to the Royal College of Radiology. In England alone, they counted 45 million acquisitions last year. Worldwide, this number is ever growing. Modern medicine heavily relies on imaging to ensure accurate and timely detection of diseases, especially with the rise of cancer cases and with an increasingly aging population that often necessitates complex image acquisitions like CT and MRI. This contributes to expanding case burden and complexity with which radiologists cannot simply keep up. With the emergence of AI technology, there is a tremendous opportunity to release this burden. With this in mind, we started Project Myra, Multimodal AI for radiology applications, with the goal of assisting radiologists in delivering effective patient care and empowering them in their work. After the release of Myra 1 in November last year, we are very happy to share Myra 2, a more comprehensive model with extended inputs and outputs. Before we get to grounding, let's talk first about radiology reporting. Just forget about gradient for now. Let's dive into it. The core task for radiologists is reporting, which is, from a machine learning point of view, an image language reasoning task. So can multimodal AI help here? One could imagine a copilot for radiology that can write a first draft or autocomplete. For those of you who use GitHub Copilot, you could imagine how handy it would be to be able to autocomplete reports. It can flag errors, but also give feedback and make suggestions. In this talk, we're going to focus on writing a first draft, which is actually a common practice in the radiology workflow, where resident radiologists draft a first version of the report that then gets approved by an attendant physician. Let's look at a concrete example. This is a chest X-ray study of a patient with symptoms of leukocytosis, which is an inflammation due to high white blood cell count, as mentioned in the indication section here. What we see here is the frontal view taken more recently. They often also take a lateral scan for completeness, given that certain pathologies can only be seen on the lateral, especially the ones behind the diaphragm, and any chronic diseases related to the spine. The technique section here describes which views have been taken for the patient. Additionally, the radiologists also examine any prior scans of the patients to monitor the evolution of their condition. With all of these inputs, the radiologist can interpret the study and write a finding section, which is a thorough description of all abnormal, but also normal observations, like there is no pleural effusion or pneumothorax. The finding section in blue here is what we will ask the model to generate. I hope this example sets the scene for what's coming next. So, to automate radiology reporting, we need three different components. First, image understanding. Radiologists often zoom in the scan, change the contrast, look at different resolution to properly examine the X-ray. And we need to be able to generate text or the finding section, for instance, all while accounting for the context of the study by including the indication section, the comparison, the technique, and also any prior studies, including both images and reports. Let's start with image understanding. We need an image encoder to extract image features from the chest X-ray. Well, you might say, just use CLIP. The truth is, CLIP is not suitable for the medical domain, since it relies on paired image text dataset, which are often available, not very available actually in large scale for the medical domain. Additionally, the text captions in the general domain are usually more descriptive and diverse, and this is not true for the radiology domain. Reports don't describe everything in the image. Normal studies are highly templated, and we often only have images without reports. So there is a great opportunity to instead rely on image-only supervision, which might be more suitable for this task. This is better actually illustrated with an example. In pink, the report mentions no significant pleural effusions or pneumothorax, which is not common in image captions since negative classes are never really described. So we wouldn't see a caption that says no dog present in the image. We also note in blue, heart size is normal without really describing what normal means. What about the patient's age, weight, shape of organs and bones? The electrodes that we can see here are not described by the report. If we rely on text supervision only, none of these would be captured. Additionally, there is a real challenge with normal cases. Look at this exam here. The report for normal studies are usually very sparse in detail. And in fact, all of these images have the same finding section and will be mapped to the same embedding space if we rely on text-only supervision. That is why our team worked on R-Dino, where we explored masked image modeling as an alternative to text supervision to capture fine-grained semantics that are crucial for radiology image interpretation. It is essentially a VIT-based model with about 87 million parameters, trained on 1.4 million chest X-rays on 5 by 18 times 5 by 18's image resolution, which is actually a step up from previous work that often operate at a much smaller resolution, usually 2 to 4 by 2 to 4. The patches are 14 by 14, and this gives us 1,369 visual tokens that will be then fed to the LLM. If you're interested in using it, we've recently shared a public data-only version on Hugging Face for everyone to advance their research on chest X-rays. Okay, let's get into the second pillar of radiology reporting, language generation. We use a relatively simple multimodal recipe based on a previous Microsoft work, LAVA, Vision Instruction Tuning. The intuition behind this architecture is actually quite simple. If an LLM can operate with text tokens in all their complexity, it can certainly learn to interpret any kind of tokens. For instance, image tokens. All we need to do then is turn images into tokens. We start from a pre-trained LLM, Vicuna, which is an instruction-tuned version of Llama 2. An image encoder is used to extract image tokens. They are then projected to the language space for alignment through a learnable adapter layer that is a fully connected MLP. We then concatenate the image and text tokens and let the LLM do its magic. This is essentially what we applied in Mira 1. We started from Lava, we replaced the image encoder with R-Dino, and applied some tricks by scaling up the adapter layer using GPT to augment the training data, but also add the indication section. If you've listened carefully, this is not enough, because we need to account for additional context beyond the indication section. Starting from Mira 1, we added the lateral and technique section when available. Next, we add the prior study, including the prior frontal image, prior report and comparison section, to finally get to Mira 2 that not only produces grounded radiology reports, which I will get into in a second, I promise, but also accounts for the context of the study with more comprehensive inputs. Concretely, this is the prompt that we pass through the LLM. The system prompt is, you are an expert radiology assistant tasked with interpreting a chest X-ray study. Given the current frontal image, the current lateral image, and the prior frontal image, the prior report, provide a description of the findings in the radiology study. So the placeholders here for frontal image tokens and all the images will be replaced by actual image tokens at training and inference time. Now, this is what the model uses as inputs, described in white, and what it generates in blue. And like prior work that don't account for additional context, Mira 2 can faithfully generate comparison dimensions in green, since prior there is increased opacification of the right lung base, and can also use the lateral there is required to identify findings like small pleural effusions behind the diaphragm, and can also assist in the detection and differentiation of conditions such as lung nodules, masses, and certain types of pneumonia. With this, Mira 2, in both 7 billion and 13 billion variants, establishes a new state-of-the-art for chest X-ray report generation, surpassing previous work by a very large margin. Let's turn that table into a more human-readable format. We see that Mira 2 achieves highest performance in terms of the more simplistic test metric based on n-gram overlap BLU4. But also the entity relation-based model, RadGraph, and JEXPERT, that identifies the presence or absence of 14 well-known pathologies in chest X-rays. surpassing not only its predecessor Maya 1, but also MedPalm-M by Google and MedVersa by Harvard. I didn't go too much in details into the metrics, but I'm happy to explain more during the Q&A session. We further conduct various ablations to control for the use of the prior study, where we show the importance of the prior and the comparison in reducing comparison hallucinations and emissions. Similarly, we study the impact of the lateral view and the technique section. For the interest of time, I will not go into too much details here, but you can check out the paper for more detailed analysis. Okay, finally, we get to grounding. I hope I managed to convince you that radiology reports generation is great, but we want to go further than this. What about grounding individual findings? We want to enable the model to localize each individual finding along with its description to make models' outputs more interpretable and also make it easier to spot any errors. For example, in pink, the increased opacification of the right lung base can be localized in this region. And in yellow, elevation of left hemidiaphragm is unchanged, can be localized here. And you can also compare it to the prior study. But what is grounded radiology reporting? It is a task that consists of not only generating a report, but also localizing all groundable findings in the image using bounding boxes in this case. The task was first introduced in a Nature perspective by Moore et al. To improve image understanding, in particular for hard to spot findings, and also to make it more feasible to understand for non-expert users, so patients like you and I. And this could also be very useful to spot any AI errors and prevent over-reliance on model outputs. We further explored this in our research study published last year at CAI. Note that this task hasn't been done before, at least not before Maya 2. Okay, let's see how we get to grounded radiology reporting. Since this is a new task, we had to start from scratch. We needed to create the data, build a model that is able to output bounding boxes along with text, and finally, we also needed to evaluate these outputs. For data, we partnered with the University of Alicante in Spain to create a public benchmark that is still being annotated at the moment, and we will hopefully open source it soon. But for this first archive version, we are actually relying on a private dataset. How do we create this benchmark dataset? We started from PatchHest, which is a set of paired chest X-rays and reports in Spanish. We used GPT-4 to extract sentences describing individual findings. We translate them from Spanish to English, and we get radiologists to draw bounding boxes on the images. We did this for about 6,000 studies that we will make available in the next few months. Now, the model. How do we get the LLM to also generate bounding boxes? For that, we discretize the images into n by n grid, where n is set to 100 in all of our experiments. Each bounding box is localized by the top left and bottom right corners in the grid, and we choose to separately encode horizontal and vertical coordinates in joint set of n tokens for x and y. And we teach the LLM to use these new coordinate tokens by adding them to the vocabulary. Concretely, this is how it looks. Each individual finding is an object that has a textual description in blue and 0 to n boxes, since we sometimes need more than one box to localize a finding. This is typically the case for findings that can be localized in multiple regions in the image, like the bilateral opacities are improving, for which we will have one box on the left and the other on the right. Also, note that not all findings are actually groundable. We don't want to localize normal findings. We only focus on abnormal findings. and otherwise we will just end up covering the entire image and it won't be interpretable. So we only focus on what can be seen on the image, and that is of high importance for the radiologists. Let's go back to our example. This is what a grounded finding section would look like. So we have individual phrases describing individual findings. So note that the pleural effusion and pneumothorax are split into separate findings. We see the phrase in pink that can be localized over here, and also elevation of left hemidiaphragm localized in yellow over here. Okay, I also promised to talk about our new metric in this talk, so let's dive into it. We need to measure not only the quality of report text, but also the grounding. And for that, we use natural language inference. You might ask, why don't you just use existing metrics? The truth is, existing metrics are very limited and don't allow us to fully capture the model's performance. If we rely on simple n-gram statistics, these tend to neglect clinical relevance. Radiology-specific metrics rely on specialized models that don't often generalize well. And finally, we need to evaluate both text and the grounding capability of the model by matching the generated boxes to the reference according to the finding phrase. In our prior work published last year at EMNLP, we showed that GPT-4 is pretty good at logical inference, so we rely on that for the metric. And actually, Llama 3 can do a pretty good job as well. So we also tested it, and we find that it's more efficient at inference. So we used Llama 3 for most of the results in the paper. Leveraging LLMs for evaluation is becoming a common practice. I can cite a few prior work, Checks Prompt, Judge, Green, and more. And in this work, we focus more on the factuality of the generated grounded reports. The idea behind RadFact is actually quite simple. We want to verify if a model-generated sentence is true, given the radiologist report. For that, we can make use of the logical reasoning capabilities of the LLMs, while also prompting them to provide the reason or evidence for the entailment verification. We can therefore quantify any hallucinations or errors made by the model. And given that we apply this on a sentence level, we get a more fine-grained evaluation, so we can know which part of the generated report is wrong and then act on that. Finally, the evidence let us compare spatial annotations, so we can infer spatial entailment and also grounding entailment that I will describe in a second. Let's see how this comes to play in practice. Given the reference ground truth report is the sentence generated by the model, there are bilateral pleural effusions, true? The answer is yes. The LLM finds there are bilateral pleural effusions to be entailed by the reference, and more specifically by phrases 4 and 5. Moderate right pleural effusion and left pleural effusion is now small. So both these sentences entail the existence of bilateral pleural effusion. Now, we apply this for each individual sentence, which gives us a measure of logical precision. So in this example, we see that 3 out of 5 sentences have been proven to be true given the reference report. Now that we measured the logical precision based on the text only, we can infer the quality of the generated boxes by matching them with the evidence boxes. We see here that the boxes generated by the model overlap nicely with the ground truth boxes that are drawn by the radiologist in gray. Now we do this for each sentence again with a box to get what we call spatial precision. For instance, here, only 1 out of 3 generated boxes are entailed by the reference boxes, since these 2 phrases are not entailed according to the reference report. So far, I described the precision of the model. So are generations true given the ground truth, which help us measure hallucinations and conciseness? And analogously, we can also define recall, which essentially measures the omission and completeness, and it's just running the same in the opposite direction. So given the generated report, are the reference report sentences true or false? With this, we get a pretty good idea of how well can MIRA2 do grounded reporting. With a pretty good logical precision and recall, the generated text is complete with high recall and accurate with high precision. In terms of spatial entailment, we have a relatively low spatial precision and recall, which means that the model generates sometimes unnecessary or incorrect black boxes. So there's still room for improvements here. But when a sentence is correct, the box is often also correct with a high precision and recall. For both the 7 billion model that is described here in green and the 13 billion model in blue. So we see a very tiny improvement from using a 13 billion model, but maybe the spatial precision is higher and more significant. Okay, let me show you one last example with MIRA2 outputs. Given the following inputs, so the frontal view, the lateral, there is no prior here, so we can see that the comparison is set to none. The technique describes the views, so PA, which is posterior anterior view, and the lateral, and the indication for long-term or current track therapy. These codes are actually code names in hospitals, which I'm not very sure what they mean. So given these inputs, MIRA2 can generate these finding phrases. The bone structures are demineralized, there are degenerative changes of the spine, and so on and so forth. And also corresponding bounding boxes for each groundable phrase. Now, using RadFact and the reference report, we can go on and verify the factuality of each generated phrase. For instance, here, we get perfect logical precision, meaning that all generated sentences are correct, and 70% recall, meaning that we successfully captured 75% of the reference report. And for each groundable findings, we can verify spatial and grounding entailment. Once again, for this specific example, we observe perfect grounding precision and recall. Actually, all bounding boxes overlap with their references and vice versa, as you can see in most of these individual findings. So given that RadFact is run on a sentence level, you can get a very fine-grained description of the generations and spot individual errors for corrections. All right, that's it. In this talk, I gave an overview with a very extended background digest of MIRA2, a large vision language model with more comprehensive inputs that account for real-world context settings, capable of not only classic report generation, but also the new task of grounded radiology reporting. We also introduced RadFact, a novel metric that can be applied for both grounded and non-grounded reports to measure the factuality of generated reports and boxes based on entailment verification. We are actually working currently on open sourcing this metric in the next few weeks, so stay tuned. I invite you all to visit our archive paper, and yeah, stay tuned for the next versions of MIRA.
Thank you very much, Kenza, for this very insightful talk around MIRA and for report generation for radiology. It was very insightful and interesting. So we have here a couple of questions. I will start by first one coming from a participant, which is quite a general question. He's asking, what were the lessons you learned when you collaborated with radiologists?
Oh, it's extremely great to work with clinicians because like as computer scientists and machine learning researchers, sometimes we tend to just think about the technical side of the problem, but we often end up solving problems that don't actually exist. So it's really important to talk to radiologists and identify what are the most impactful research directions to take. So we often do like brainstorming sessions to dive into what is actually important for radiologists to speed up their workflows. And also I get to learn a lot about chest x-rays, which is quite nice.
Yeah, this is the perks of working. I mean, in data science, you work with other experts and you
Yeah.
learn many things from other fields and domains. So thank you, Kenza. I will go to the second question. It was about the Myra model and is the prompt engineering plays a role in results in generating reports, or is it the same likewise?
I think it's pretty much the same. So we're not doing proper instruction fine-tuning. We're specializing the model for a specific task, which is findings generation and grounded report generation. So the prompt is actually fixed. We don't envision the model to be deployed as a chat model. So we don't really focus on soft prompting or like variations of the prompt. Because yeah, like this question keeps coming back because a lot of, with all this hype about like chat versions of models, everyone wants to deploy chat models, but for radiologists, they wouldn't like just interact with it as a chat model, but rather use it for just findings generation or report summarization. So the prompt for this specific model is not really important. You could, like, there is more, I can think of other work like checks agent, which is actually an agent. So it's more instruction fine-tuning that you can then interact with as a chat model.
Okay, clear. So the focus was more on the reports than the prompt engineering. We have another question, two questions indeed, around the boxes that you use to segment the image. So the first question, a participant is asking if you can explain why you added the X and Y box tokens to the LLM vocabulary. And the second question is does the how the X-rays, the images were segmented to generate those multiple boxes within the X-rays?
Sure. So maybe that wasn't clear, but what we do is we discretize the image into a grid 100 by 100. So each coordinate is like a normalized version of this grid. And the choice of X and Y was mostly based on prior work as well. So this is inspired from prior work in Cosmos 2, Unitab, and Pix2Sec. That they apply a similar strategy for discretizing the grid. It is becoming more common to get the LLM to actually output bounding boxes, but you can also do, instead of getting it to output a bounding box, you can output a special token for bounding box and build on top of that a regression model to do like proper regression for bounding box generation. The second question, I guess, was about how did we get these annotations? So these are annotations by expert radiologists. I've described how we did it for patches, but it's for the private dataset, it's pretty similar. So we start from the findings section, we break it into individual findings, and for each individual finding, we get the radiologist to draw a bounding box on the chest X-ray, and we use that as training data. So in the paper, we used about, I think we have two benchmarks, one using 60,000 image studies with annotations, and another more fine-grained one that we use for evaluation that only has 8K. And we are releasing this public benchmark for patches soon, hopefully.
Thank you very much, Kenza, for those clarifications. They do add more insights to the talk. So we have another question about the versions of Mira. So there are the Mira V1 and Mira V2. And Yassine is asking what is the difference between the two, and also asking if the models are open source.
So the difference between Mara 1 was the first checkpoint for radiology report generation. So it's not something that the team had worked on before. So it was the first attempt to solving the problem. We started from a very simple scenario with just a frontal image and get the LLM to generate the finding section. And with Myra 2, the hope is to augment this with like more comprehensive inputs. So we added these multiple views, so the lateral view, comparison to prior work, and also all the available sections. So the technique, the comparison, the indication, we used it already in Myra 1. And on top of that, we're doing grounding. So this is, you can actually use Myra 2 as a Myra 1 for if you simplify it. But I had actually, let me go back to that. You can see how much improvements you get by using these additional inputs. All right, I'll get to it in a second. Over here. So by adding the multiple views and the multiple sections, we improve brute force. So in dashed lines, it's Myra 1. And also clinical. So this Checkspert macro F114 identifies the absence and presence of 14 pathologies that includes pneumothorax, pleural effusion, I think cardiomegaly as well, and some others. And we see that the model not only improves on the text side, so like just the lexical side, but also on the clinical accuracy. So the macro F1 improves quite a lot, and we see that also on logical precision, that goes from 48 to 55, and similarly for recall. So we're generating more complete reports and more accurate reports. Are these models open source? Not yet. We're working on that. Hopefully we might open source a public version because it's trained on some private data, so it's hard to open source it from a legal point of view. But hopefully we can get an open source version soon.
Hopefully, looking forward to using the open source. And another question in the same sense context, like, can we use the Myra model for other radiology reports in other languages?
So at the moment, we only have support for English, but it should be very easily extendable to any other languages as soon as you have the data. So the recipe is there, the paper is there, you can apply it. So if there is like a specific data set that you have, you can just train a model and get it to generate that in a specific language that you want.
Yeah, so we just need to put data in a specific and we will get results. Very nice. So we have another question regarding the quality of X-rays. Does this impact the accuracy, or do we need like high quality X-rays to have those good results in report generation?
That's a very good question. Real world data is a mess. It has been very challenging to work with all of these data. We're training on about, I think, 500,000 studies, and we have 1.4 million chest X-rays, so image only. And you can't imagine what we found there. Sometimes it's just like a black image. Sometimes it's actually the report, the image of the report. Sometimes it's, and there's a lot of artifacts, and it's really hard to get rid of all these artifacts. I wouldn't go into like trying to create high quality clean data set, because then the model would only perform on high quality chest X-rays. So it's also important to let the model deal with noisy data and try to figure out how to deal with that, because in real world setting, once you deploy a model in a hospital, it will get crap for sure, and it should know how to deal with that.
Yeah, trash in, trash out. That's for sure. And another question, like, and the overall view now, like that you have this great work like looking in hindsight, what was the most difficult part of your work? Like it was like more data cleaning, image understanding, language generation. What was the most challenging part?
Data processing was the most challenging part for sure. It has been a long journey. It's really hard to, especially because we started with this new task. We didn't have the data. We had to annotate it. We had to think about how to extract all of this data. And yeah, we did it this way, but there is a lot of ways of doing it as well, I'm pretty sure. But I think once you start working with real world data, it's often very challenging to, we spend, I think, 80% of the time just dealing with data and 20% just having fun with the model.
Nice to hear. So once you are done with data, you have everything. That's
Yeah,
good.
exactly.
So we have another question, like model wise, is it like what were the techniques that you used to reduce hallucinations other than grounding?
That's a very good question. We're actually looking into RLHF, well, RLAIF, so reinforcement learning with AI feedback to further improve, like reduce hallucinations. So as I've described, I think we have an image not so far from here. Previous work usually just looked at the frontal image and they were like kind of generating comparison hallucinations. A model cannot really figure out scenes prior if it hasn't seen a prior. So giving these additional inputs is actually reducing hallucinations, and that's what we show in the various ablations that we describe in the paper. There's also an appendix section for each section as well, for the comparison and the technique as well. And you can see, you get a lot of insights from that. And it's usually just playing with the data. We often make this joke, if you teach a model to hallucinate, it will hallucinate. So if you don't give it the appropriate inputs, it won't be able to properly generate, but faithfully generate the right outputs. So it's really, really important to think about what you need to give the model as input to actually generate something that is meaningful and that makes sense with limited hallucinations.
Okay, very interesting. So this brings us to another question is about flagging AI reports generated. So do you plan to flag those reports so that the patient knows that the report was AI generated? What is your strategy?
So we haven't got to actual deployment, so we get to do the research and the fun part. But I can imagine that once you deploy this in a clinical setting, you should definitely work on regulatory to make sure that the patient is aware that the report are generated by an AI. And also, I wouldn't just all of what I've described, we think about it as draft reporting, but not actual reporting. We keep saying that a radiologist needs to look at the report and make sure that it makes sense. You can't just let an AI generate reports in the wild and trust it completely. With grounding, we hope that we're making the outputs more interpretable. So we will be more easier to flag errors. Also, like for the patients, make it more easy for them to understand their conditions. So if you tell someone that, okay, you have a pleural effusion, it's over here, this is how it looks, it's much more understandable than just a report saying there is pleural effusion. But going back to the question, I started deviating. I'm pretty. We need to. You can imagine some watermark versions of like to make sure that you can distinguish AI generated reports from actual reports. Another topic that is very close to our heart is structured reporting, which actually is a much debatable in the radiology space. So instead of just writing these free text reports, you could imagine a structured representation. So for each individual organ, you have a set of things that you need to describe, and it's much more structured, much more controlled. You can evaluate it more easily. You can and then there isn't like much room for hallucinations and like just letting the model generate whatever it wants.
Oh, that's very interesting. Is it like more in it, like a digital twin for all organs that we have, and so that we understand the organ, we can generate the reports more easily?
Even like within radiologists, they keep going back and forth on like the way they're reporting, because like each radiologist reports in their specific style. And it's very hard to actually evaluate any of this. We had to come up with a whole new metric to just make sure that we're generating the right thing. So having a more structured representation would make it much more easier to just match the entities and relations. So one of the metrics is called RadGraph. It's actually extracting all entities and their relations and making sure that the entities in the generated and reference reports are matching, and also their relations. So if you have, instead of having just free text, you can have just a graph representation of the chest X-ray. I think it's from a computer science point of view, we just want to automate everything, so it's much easier to have everything structured, but in the real world.
To model everything. Yeah, makes sense. But for sure that will help to speed up the report generation and help a lot of radiology experts. That's for sure. I mean, the this is like it's paving the way for this in the
Mhm.
patient care. And for the sake of time, I will end with this last question. Is like, what is your advice to engineers, researchers that would like to work on the same subject for report generation in healthcare and radiology?
Um, I think luckily there is a lot of public benchmarks, a lot of public data sets. With like you need to do some trainings to get access to them. But so we're using Mimic CXR, and there's a lot of a big community that is currently working on report generation. So I would advise to get familiar with the literature, get to know how people are approaching this task. And maybe one thing that is quite interesting to look into is how to transfer general domain research to medical domain. It's not always easy to take a ready recipe from something that has been trained on ImageNet and apply it directly to medical imaging. It doesn't always work. So understanding that might be very insightful and helpful. And also maybe it's a very crowded research area. So also thinking out of the box and thinking about challenges that are not very explored at the moment. I would think about interpretability as one of the most important areas to work on. We don't really understand how the LLM is interacting, like all these text and image tokens, we don't really understand how they are working. So there's a lot of, I'm happy to grab anyone who's thinking about getting into research for that and like brainstorm ideas about that. There's a lot of things you can do. And yeah, open sourcing is key. Whenever you have the opportunity to share your work, it's very important to make the research more accessible for everyone and advance it. It only helps to share with everyone.
Yeah, indeed. Thank you very much, Kenza, for all your answer, the great presentation, and also the clarifications that you brought up. So we invite all the attendees to join us to the breakout rooms where we'll have the chance to ask Kenza directly about your questions, your concerns, or any explore, brainstorm any future direction for your future research. Thank you very much, Kenza. And
Thank you so much for having me.